Hi, everybody. Okay, so let's get into Module 3. This is Chapter 5 and the beginning of Chapter 7. I think that the beginning of Chapter 7, talking about delivery models, continues the discussion of application of evidence and evidence-based practice that is covered in Chapter 5. So we're just going to begin that, and then the following module will kind of combine the content in Chapter 7 and talk about program design and development, but also kind of implementation of evaluation methods. So let's go ahead and get started. By the end of this module, you should be able to gather, appraise, and synthesize information to design evidence-based interventions. This is what the PICO assignment is kind of initiating. It's really just initiating all of this because you are using the PICO assignment as a kind of dry run for what your project at the end of the semester is going to kind of culminate into, but going through it in a stepwise methodology, I think, is going to help you kind of absorb and understand the reasoning for why we go through the steps. Identify steps to engage partners in a culture of evidence-based practice and learn how to design new programs by addressing factors related to planning and organizational decision-making. So that last objective is, we're going to sort of start that discussion, but not necessarily cover all of the content in Chapter 7. Chapter 5 is pretty dense, and I don't want to shortchange you guys in terms of going through the information, but also not overwhelm you in terms of the amount of time that this lecture should take, because I don't think it's valuable for you to sit and listen to a lecture for a long time. So in general, we know that nurses improve the health of populations by providing evidence-based care. We focus on evidence-based practice, as we talked about before, because we've moved away from doing things just because that's the way we've always done them or because of anecdotal evidence, and instead focus on grounding our interventions and the culture in which we practice in evidence and clinical standards. APRNs learn, research, and critique, and possess scientific knowledge and clinical expertise. I think owning this role and acknowledging it is critical. I fear that there's a tendency when advanced practice nurses get into practice in the clinical setting, whether that be in psych mental health nurse practitioner practice or in a family nurse practitioner or primary care kind of setting, that things become very task-oriented, much like the way that when nurses get into the hospital or a clinic setting, they can become very task-oriented. And I think it's critical to recognize the skills that you are imbued with through your graduate career, and not lose sight of that when you get into practice. And I say lose sight of it. I don't think that you're losing sight of it. I think it's unfortunately the way that other practitioners may perceive you, that they may see you as a mid-level provider who doesn't necessarily have understanding of the evidence base underpinning the clinical decisions that you make, and that your focus is, task-oriented, which it isn't. You have the scientific knowledge to apply critical thinking to the decision-making that you're doing as a clinician. And that is a valuable asset, and it's a unique skill set that should be acknowledged and respected. And then we need research methodology to support evidence-based practice and the ability to translate knowledge of sciences into practice that we can't just say that we're doing evidence-based practice without actually doing it, without actually grounding our practice in research and ongoing review of the literature, and staying apprised of best practices and changes in the field, by maintaining your professional licensure, maintaining your association with professional organizations, reading those journals when they come in on a monthly basis, being a member of a professional organization like the American Nurses Association, associations for specialty organizations, etc. All of those contribute to the quality and the elevation of your practice. So, what is needed for evidence-based practice? The ability to identify the clinical problem, recognize any safety issues that may be at play, composing the clinical question to direct the way that you're going to approach the problem, and the way that the research problem is going to be analyzed. Conduct a review of the literature, appraise and synthesize the evidence that's collected, and then integrate this new knowledge into practice. So we'll be going sort of through these steps and skills through the rest of the presentation today. So the first step is to ask the clinical question. You observe something, a phenomenon in your practice, or you read an article that prompts you to question whether what you're reading about could be applied in your own setting, and you ask these possible questions. Why is this happening? Why am I observing this phenomenon in my patient? Would this work in my setting? You read something in a journal article and you wonder if this is something that could improve the quality of the care or improve the efficiency with which care is delivered in your setting. Could this approach be adapted and improved? You read something and you read a journal article, for example, that intimates that results were limited because there wasn't an adequate sample size for the population. Could you replicate that in a larger population yourself and contribute to that body of knowledge? And then what else are people trying to address? What else are people doing to try to address this issue? Sorry, that's a typo. But what, in addition to what's proposed in the article, oftentimes in the section towards the end of a journal article where they go into some of the constraints of the intervention or some of the limitations of the study, they can identify possible additional areas of investigation. Could one of those be something that you take on and you use to examine the problem kind of from a different lens or through a different lens in your own practice? So the framework that is proposed in the text and what is used to examine the problem is this PICO framework, and this is what your assignment this week is on, to organize the way that you examine the problem. They use this acronym, the population, and then examining the phenomena of interest, looking at the context, examining what outcomes may be, and then finally, is there a time frame in which to consider the issue? So just to dive into the PICO methodology a little bit more, the issue with the reason why we're going to be talking about literature review and quality of evidence and everything, it's because in order to ground your problem, and in order to provide a context for the intervention that you're proposing or the question at hand, you really need to be able to put some parameters on it. So in order to put boundaries on that population, you need evidence. You need something that provides an outline of what is included and what's not included in the problem that you're trying to solve. So you're looking at an issue with smoking. It needs to be refined. You can't just say, why do people smoke? Because you would be, studying that for the rest of your life. But instead, to refine it down to you observe in your clinical practice that more men than women smoke. So why do more men than women? And you determine the age group. Why do more men than women over the age of 35 smoke cigarettes as opposed to vaping or some other type of tobacco use, chewing tobacco or something? So that refinement of the population helps you to reduce the scope. It also helps you to get down to nuts and bolts, and figure out what kind of literature would be relevant and included, as opposed to just throwing wide the doors and saying you're going to look at everything, and then you end up lost because if you don't have a really focused research question that's very clear and concise, the result is also not going to be clear or concise. So the population part of it involves looking at the population to be studied. The background literature should be relevant to that targeted population. So you're not going to look up a bunch of information about men who smoke over the age of 35, and then all of your evidence is focused on smoking among pregnant women. It's just not relevant. So it also helps you to refine your search terms when you're doing an analysis of the literature or doing a search of databases and so forth, to make it as refined a population as possible. The second is to look at the phenomena of interest. What is the intervention that you are proposing to examine, and what is that, or the intervention, or what is the phenomenon, or the I forget what the word I just used a few minutes ago was, but whatever observation that you're seeing among the population that you want to learn more about. What is it? That's sort of the I part of this. C is the context, or the comparison. What is a group that you could compare your population of interest to, and how do they what are the environmental or other factors that impact that group? And then finally, what's the outcome? What does the nurse want to see improved? What does she or he expect to accomplish? And what's the intended change that you want to see happen? And then finally, the time frame is sort of like, it's in parentheses because it could or could not be used. It's not necessary every time, because it may not be something that you could realistically put an endpoint on. But it is always good to think about what some realistic time parameters might be, even if you're not necessarily putting a time frame on it. For example, if you're talking about this smoking among older men, if you were to institute a proposed, smoking support group intervention, what does the literature say about the time frame that those kind of interventions are useful, have been useful for, or have been effective in impacting. So time frame isn't always necessarily like a specific series of milestones. It could be what's a realistic expectation for a period in which change could take place. The evidence pyramid is included in the table in table 5.1 in the chapter, and I was having a hard time with this because the number of tiers in the evidence pyramid that I'm familiar with is typically a 5-tier pyramid. This one is a 7-tier pyramid, but I think it's just because it sort of breaks out that descriptive or qualitative study at level 6, whereas some of the other evidence pyramids that you may find in other sources, they don't break out cohort and case control studies separately. They're sort of grouped together, and expert opinion may be part of case reports or case series, and so there may be fewer tiers in some of those. But I think I found this graphic useful because I think I think it still does show the same kind of levels of evidence. In the textbook at level 1, the top of the pyramid, are systematic reviews and meta-analyses of randomized controlled trials and evidence-based clinical practice guidelines. So that's still the same. I think it's just adding in the systematic reviews and meta-analyses of our CTs. And then on level 2, multiple RCTs using kind of the same criteria and comparing the same methodology but in multiple attempts. So performing a randomized control trial with the same inclusion criteria, the same methodology among the same population multiple times increases the likelihood that you're going to have consistent results, and those consistent results should have a higher level of validity because you really are doing the scientific method. You really are kind of proving the hypothesis. At the next level are randomized controlled trials, and they're lower on this pyramid than this evidence-based guidelines at the top, because really randomized controlled trials typically don't take place in the real world. They're very idealistic, and so therefore the population is a smaller outcome, a smaller population in which to study the outcome of interest, and it's hard to generalize when you are holding people to such strict criteria, those that are required for conducting a randomized controlled trial. Cohort studies and case control studies, while they are bigger, typically larger groups of people, it may be harder to tease out the causative factors in those kinds of studies. And then the same thing with case series, case reports, and finally like expert opinion and what do you call these? Descriptive studies that just describe a phenomenon that's taking place in a population, or an expert who's writing an opinion or a letter to the editor, or a synthesis of their experience. It's valuable because that person's anecdotal experience is valid, but it's not evidence. It's experience, and so there's not necessarily as much generalizability, or it's not as based in fact. So at the lower end of the pyramid is a lower quality of information. There's a lot more of these circulating because the criteria to be published in articles in journals that are more selective are higher. So it's more difficult to be published without having more stringent research methodologies. And those research methodologies of journals that are more selective are, are able to weed out some of the lower quality studies, but it's not that those studies don't still get published elsewhere. That's kind of the point. At the top, there are fewer articles that meet those criteria because it's more difficult to do a meta-analysis because there may be fewer of those randomized controlled trials to choose from. So you can't do a meta-analysis unless you have more than one study to analyze. At the top of the pyramid, these are syntheses of the best available evidence. So at the top of this, for example, would be Cochrane reviews of evidence-based interventions, where it's been studied so many times and the methodology has been validated, and they're clearly saying, based on the evidence, this is the way that this should be performed, or this is the way that we should be doing XYZ approach to practice. It's the same for the U.S. Preventative Services Task Force. When they come up with their recommendations, it's not a haphazard or a linear kind of a process. There's multiple committees looking at different aspects of all of the recommendations, and then there's a review process, and there's an analysis of the quality of the studies that are backing up those recommendations. So those require a lot of energy and a lot of time, and so therefore there are fewer of them, and they're restricted to a certain number of entities that are taking on that very kind of burdensome process. So at the top are syntheses of evidence, and at the bottom are studies, which are more descriptive. So when you look at evidence to back up your interventions, you have a lot of opportunity to validate your work here at the university. We have extraordinary librarians. Our librarians are ready and willing to do searches for you, to help you learn how to do searches yourself. They're happy to, you can give them a topic that you want to learn about, and they can help you to refine your research question. And I really would encourage you to avail of those experts, because they have skills at, for example, in the chapter where they're talking about Boolean search terms and how to really kind of cultivate the best search criteria, and how to refine the terms that you use to conduct a search. The librarians may have done a search on a similar topic in the past, and so they may already have some, sense of what's out there and what's not, and whether you're kind of headed down a dead end, or whether there's actually, another source of information that may be more valuable or more accessible, or, more interesting even. They may be able to help you even with your research question, because they may, have a sense of what's already out there. In particular, research librarians at universities and at medical institutions, at state libraries, they're an exceptional group of people, and they're so dedicated and easy to work with and just underutilized. So I really would encourage you to get to know your librarians at this at the library here at the university and look at what they have available. That said, the website is also very, user-friendly for the O'Connor Library. Is it the O'Connor Library? No, it's the O'Connor Fitness Center and the Pope Pius Library. I apologize. But there is a listing of different research databases. So they have, like, in the chapter they're talking about CINAHL and EBSCO hosts and all these different databases that you can search. But they also, in the research databases section of the website, have it broken down by topic. So you could go in and look at the nursing databases that are already lined up for you. If you just search on the left-hand panel down alphabetically, there's a section for nursing. But if you're looking for a different source of information or a different take on a topic that you're looking at, they also have, pharmacy or medicine. They have other types of databases that may be more relevant to you based on the approach that you're looking at. If you're not necessarily looking at a hospital-based intervention or a primary care-based intervention, and you want to look at something in the community, there may be a different database. But again, I really would just encourage you to consult the librarians and just, browse through and get familiar with the research library. So how do you assess the evidence? How do you determine what's good evidence and what's not so good evidence? And how do you organize it so you can keep track of it? Part of this is to make your methodology transparent. So if someone was to come behind you and say, I read your article, I read your journal article, and I have some concerns about the conclusions that you drew. How did you come to those conclusions? One of the first things that you could show was your methodology in examining the literature that you were using to back up your chosen intervention that you were proposing, or your analysis of an existing intervention. So keeping track of the articles, keeping track of the authors, looking critically at their credentials. Is this an article about a nursing intervention that's written by physical therapists and occupational therapists, and it doesn't necessarily really have a context of what nursing is? Or, is it a article about nursing that's written by physicians? There's something to be said for nursing research that's conducted by nurses, and how that may that position, the person's position and professional preparation may bias their interpretation of results or assessment of the literature and conclusions in terms of the analysis of the data that they're looking at. And then what was the research question in this article? It doesn't necessarily have to line up word for word or even topic for topic with your research question. You may, for example, in that we were talking about men over 35 who smoke. You want to know, why do they smoke? Well, maybe you read an article about occupational smoking characteristics among auto workers in the in the New England Rust Belt corridor, and you determine that their research question is different from yours, but it may inform your research question, and so it's still a relevant article. So the question part of it is really also to determine what was their research question, and then why is it relevant to the question that you're looking into. Your study design, did the research in the article capture what it was designed to examine? So that's questioning whether it had internal validity. Was it accurately studying what it was setting out to study? And then how well can the study results be applied elsewhere? That's the external validity of the research. The level of the evidence. So this is where you would look at your research pyramid and the evidence pyramid and determine, where does this fall? Are you looking at a case control study? Are you looking at a randomized controlled trial? Are you looking at clinical guidelines? Are you looking at a evidence-based clinical practice guidelines as opposed to guidelines from a textbook, which they may not necessarily line up. So just rating each of those so that it's clear what the level of evidence you are looking at is. And then describing the sample population. Who did it study, and are the results relevant to other populations? Are they generalizable? Is this discussed in the article? Are the limitations of the population recruitment design discussed, and how do those affect the way that you might design a recruitment strategy? So all of those are relevant elements. What measures were used, and how applicable would those indicators be in other settings? So what are the mechanisms to assess success or failure in the study that you're looking at? And then finally, were the results what were expected? Was there anything that was surprising? What information was gleaned by this study, and are there any flaws in the design that impacted the results? So in the textbook, they talk about the idea of the sacred cow, and this is sort of what we've been alluding to even with the first lecture, Module 1, that we can't keep doing things the same way we've been doing them, and when questioned why we do it, say that it's because that's the way it's always been done. So the chapter references this article in the nursing journal that looked at, I think it was, I can't remember what year this was, I think they said it was 2014, but it was, let's see, make sure that I'm not misstating that. So the point was that that this group looked at like 14 different practices and asked a group of nurses whether these were evidence-based practices or just a sacred cow, like something that we do because we've always done it that way. And that there was surprisingly not as much accurate identification of which were evidence-based practices and which were not. So the example that I posted up here from that article are patients experiencing hypotension and shock should be placed in Trendelenburg position to improve blood flow to the heart and brain. This is actually false. Trendelenburg has been studied for the last 50 years, and most studies show no improvement in cardiac output or blood pressure with its use, and that any cardiac improvement or blood pressure stabilization usually lasts less than 10 minutes, and yet we still do it, and that 51% of us, and I say us because as a nurse I'm thinking as part of the population, that if I was asked, is Trendelenburg an effective way to reverse hypotension, I would say yes, because in nursing school that was, one of the things that we learned, how to, push the feet of the bed up so that we can get a dropping blood pressure stabilized mechanically. And yet here we have the evidence, and that it's been studied for the last 50 years. It was a surprise to me even. At the bottom of this, they provide the references, the studies that they base this off of. But the point was not so much to like have a gotcha. It's more so to show how widespread, even among nurses that consider themselves to be doing evidence-based practice, there's a tendency for us to do things either the way that we've always done them, or the way that we were taught, or the way that seems logical to us. And I found it interesting, the section where they were talking about mind lines, this study where they looked at what motivated people, and they called it mind lines instead of sacred cow. They referred to these internalized guidelines that are formed primarily from interactions with colleagues and people perceived as opinion leaders. The day-to-day practice is based on socially constituted knowledge, and that the only way to really reorient these mind lines, these like kind of automatic ways of thinking that the next step should be, or the appropriate response is XYZ, or the reason for this is whatever we have in our mind, is to reorient people to follow opinion leaders who are well grounded in evidence-based practice, so that we can actually transfer research to clinical practice. So, this goes back to in public health, we really find value and find the way to change people's behavior is not to. We used to think if we just told people, and if they just understood, and they cognitively, intellectually understood the reason why something is bad for them, that they would change their behavior. What we know now is that public health telling them that, or a nurse telling them that, is not as effective a mechanism to tell them to change behavior. Behavior is internally motivated, and it's motivated by so many different factors. But one effective mechanism is to determine who the thought leader or who the trusted messenger is in the community, who, if they told them that, so if your sister tells you that breastfeeding is the best thing for your baby, and that you can do it, you can get through it, that's more motivating than your doctor saying, the best thing is breastfeeding, and leaving it at that. That the trusted messenger is so much more powerful. So I think it's very similar to this idea of mind lines. Like, the only way that you're going to undo that automatic way of thinking is to kind of reset and reorient to another source of, best information, but also trust is such a big part of it. So they identified 4 different evidence-based practice models. This is the ARCC model, the chronic care model. They also identified the Johns Hopkins nursing evidence-based practice model, and the Iowa model of evidence-based practice to promote quality of care. And in the book, they have the Iowa model to increase breastfeeding initiation as kind of a case study. These are organized approaches to integrate evidence into practice and sustain change. And the value of having a model is that there's less variation. We know that variation increases risk, it creates gaps in care, it creates the possibility that, one person interprets something their way, another person interprets something differently, and that gap is where accidents happen, and sentinel events tend to occur as a result of these kind of intersecting constellations of new ideas, but the gaps in between are where accidents happen. So it's critical that we think about developing programs with these kinds of criteria in mind, that programs should be developed based on the evidence-based practice models, and then building those out into effective programming. It should always be based on good information that's accurate, timely, pertinent, relevant to the population that you're talking about, takes into account environmental limitations, things like transportation or the income of the population you're talking about, or the reading level of the population, or temporal factors. Are you going to have a very successful program if you're trying to initiate that program over, an important holiday in a community that is going to be distracted by that holiday preparation during the time when you want them to be studying them responding to the proposed intervention, for example. And then determines mechanisms for evaluation in the planning stage. It's so critical to be always thinking about evaluation from the beginning of the process, so that you're building it in and building in those ways to evaluate into the actual implementation model, so that it's not an afterthought and you can collect the data that you need, right from the get-go. And also get people on board with being part of that data collection so it's not perceived as burdensome. Robert Wood Johnson Foundation in 2008 identified some innovative care delivery models, and I love Robert Wood Johnson Foundation. Is just one of my favorite websites to tool around in. But they identified 8 common elements that were noted throughout the models that they studied and categorized into acute care, bridging the continuum, or comprehensive care. And the common elements were the importance of an elevated role for nurses as care integrators, not just as caregivers, that there should be a migration to interdisciplinary care, that having a team approach is more effective because it meets the multiple modalities through which people change behavior, but also the multiple needs that people have simultaneously, that you can't just attend to their physical needs and ignore their mental health needs, for example. But when attending to their physical and mental health needs, you can't ignore the fact that they don't have money to buy dinner. So it's always a team approach that works best, because then you have greater buy-in by the other people on the team that are going to assure your success. Bridging the continuum of care, so making sure that once the person leaves the hospital, that they go into a rehab center in the community, that when they leave rehab, that they have home care following them. When they are finished with acute home care, that they still have some connection to their primary care, and that there's an assurance of continuity throughout that whole that process. Pushing the boundaries, making sure that we're thinking about home as a setting of care, and that we're not requiring people to come to us, that we're going to them. Targeting high users of healthcare, the elderly and those with mental health conditions, those experiencing homelessness, others who are higher users of healthcare, we can efficiently care for them. It reduces a lot of burden and strain on the health system as a whole. Sharpened focus on the patient, so not just giving lip service to patient-centered care, but actually centering our care around the needs of each patient as an individual. And then leveraging technology in care delivery, making sure that we're not just using the electronic medical record, but also introducing phone applications that may be more useful to our patients than handing them a paper that they're going to stick into their backpack and lose. And then driven by results, improving satisfaction, quality, and costs. So in looking at those themes in ways to improve care, they identified in this white paper that nurse leaders consider the following elements in program development, regardless of the type of care. So regardless of whether it's in acute care or bridging the continuum or comprehensive care, and that there always be a specific population focus, that the more specific the population focus, the more effective the care, that it always be a team approach, that there be a consideration for a continuum of care, strategies to engage the patient or the client so that they can be informed participants and directors of their own care. Teaching and education has to always be a part of the model, and then a focus on results or outcomes. And I would add, in teaching or education, I think motivational interviewing and other techniques that are have been shown to more effectively convey information than our more traditional way of teaching people, which is actually not really adult learning. It's actually very pedagogical. Flyers and handouts and sending people to classes and so forth are not necessarily the way that adults learn. And so it's important that we be cognizant of adult learning styles and development. So in summary, adopting evidence-based practice is culture change, and there will be resistance, and it requires structure. The tools in these chapters offer ways to promote consistent integration of evidence into practice and to promote best practices. Nursing requires critical thinking, and APRNs need to appreciate their responsibility and their opportunity as thought leaders with credibility as they assess opportunities for practice improvements. Programs will only be successful with structures that support accountability and outcomes-driven operational processes. So as I mentioned, we just kind of got into the beginning of Chapter 7. So the next lecture is going to include the other part of Chapter 7, because I think it gets into some of the elements of program design that go a little better with evaluating practice. So these chapters, at the beginning, they go together really well, but then as we move through the rest of the book, I'm finding that some of the parts of the chapter go well together, and then others kind of seem like they're stuck together a little artificially in the book. So I appreciate your patience as I am, working through this book myself, and I wasn't familiar with this text, so it's a learning experience for me. Thank you for hanging in there. This was a long lecture, and we'll be back next week. Thanks.